Good afternoon, everyone, and welcome to this live webinar organized by the American Society of Echocardiography. I'm Carrie Altman at Texas Children's Hospital in Houston. Several weeks ago, ACE published a statement on the protection of patients and echocardiography service providers during the 2019 coronavirus outbreak, and with an update on April 1st. The emphasis in that statement was the adult patient population. The ACE Council on Pediatric and Congenital Council wanted to address our additional concerns and factors in the population of patients that we serve: infants, children, congenital heart disease throughout the age spectrum, and pregnant women and fetuses. Therefore, we published the above supplement to the original statement with endorsement from the Society of Pediatric Echocardiography and Fetal Heart Society. Today, our panel is going to discuss important features of this addendum, this supplement. Our panel includes Piers Barker, who's chair of our Pediatric and Congenital Council at ACE, as well as the head in the writing group here. There are Mark Lewin and Matt Kronman from Seattle Children's, and then Mary D'Onofrio from Children's National in DC. Next slide. We wanted to also thank the other members of the Pediatric Supplement Writing Group, including Greg Ensign, Bana Arya, and Madhav Swaminathan. And we also wanted to definitely thank our webinar sponsor, Hitachi, for helping us with this webinar. And also behind the scenes, I'd like to thank the ACE crew of Liz Lane and Christina LaFuria, because we couldn't do it without them. The outline for today's talk is that we are going to have an update from Matt Kronman in Seattle on a clinical update on COVID-19. Then Mark Lewin will talk about the Seattle experience and help us understand who, where, and how to image. And then Piers Barker will take over on the PPPE front about protection, personnel, POCUS, and equipment. And then Mary D'Onofrio will take over to discuss fetals and consideration during pregnancy and delivery. And then back to Piers for TEE for pediatric and congenital patients. We will have time at the end, probably 20 to 30 minutes, to answer your questions, which you can submit via the question and answer box at the bottom of your screen there. I'll collate those and send them out to whoever needs to answer them. And so you know that this session will be recorded and will be available on the ACE website subsequent to the webinar. So let's go ahead and get started then. Next slide. And we'll start with Dr. Kronman.
Hi there, thanks so much for having me today. On the first slide, I'd actually just like to review the global situation on the next slide, please. Where using data from Johns Hopkins, this is a screenshot that they collate, and there have been just over 1.5 million cases of SARS-CoV-2 COVID disease confirmed worldwide. These data are from yesterday afternoon, and as of today, actually, there have been more than 450,000 cases in the United States and more than 93,000 deaths worldwide. And I'll also just draw your attention to the bottom right. In orange, the epidemiologic curve of new cases continues to rise at a brisk pace. Next slide. Oh dear, I'm not seeing the slides any longer. Let me try to, if you could reshare the slides. Well, let's try this. So on the next slide, I'll just briefly talk about the incubation period and a few virologic characteristics. So the mean incubation period appears to be 4 to 5 days at median, and the range is 2 to 14 days. Yes, Liz Lane has started screen sharing. Wonderful, thank you. And so we believe that this infection is mainly spread by droplet and contact, though there's also concern, of course, that it can be spread by aerosols. One thing that is making this infection particularly hard to contain is the fact that about 20% of people may end up remaining asymptomatic during their entire infectious period. And there's also increasing convincing data of transmission shown on the next slide, that people can be shedding virus for 1 to up to as many as 3 days prior to development of symptoms. And so there are case reports that people in their pre-symptomatic period have transmitted the infection to others before they even felt sick themselves. However, we do feel that the transmission risk is highest in those who are symptomatic because they're coughing and generating those respiratory droplets and aerosol. On the next slide, please, I review a little bit of data from the initial experience in China and Italy. And on the left-hand side, you can see in the red box that the minority of cases are in children, 1 to 2% in total. The pie chart shows the same thing in that lavender small wedge, 1.2% in Italy. And on the right-hand side, you can see, again, in that red box, that the case fatality rate increases dramatically with age. So children really don't seem to be dying from this infection, but the case fatality rate increases after the age of 60 or so, and can be as high as 20% or more in those over 80 or 90 years old. Next slide, please. And this week, the CDC released data in their MMWR outlining all of the pediatric US cases from February 12th to April 2nd. And they likewise identified that in those 2,500 cases, out of all of the US cases, those were in children, and that represented just 1.2% of all US cases, despite the fact that children make up a little more than 20% of the US population. So children really don't seem to be getting this infection or coming to medical attention with it. On the next slide, we just briefly review the symptoms that children and adults can have with this infection. And you'll see children listed on the left tend to have fewer of these symptoms than adults, but the common symptoms are fever, cough, shortness of breath, as well as myalgias, runny nose, sore throat, headache, and some will have GI symptoms. On the next slide, one of the many million-dollar questions for this infection is, why do children have the infection at such a lower rate or have fewer symptoms? And really, we don't know the answer to this at this point. It's speculative. One hypothesis is that children lack a mature immune response and therefore can't have that over-exuberant immune response and cytokine storm that adults seem to have. On the flip side of that coin, others argue that perhaps older adults, their immune system has waned and they don't have the ability to contain the infection in the way that children do. Another hypothesis is that children frequently get upper respiratory tract infections, and many of these are caused by other common coronaviruses, not SARS-CoV-2, but that those infections provide some cross-protectivity against the SARS-CoV-2 infection. And lastly, some people have hypothesized that children have a different distribution of the ACE2 receptor in the lower respiratory tract, making them less susceptible to having disease in the lower respiratory tract compared to adults. But all of these are really hypotheses at this point. And finally, on the next slide, I'll just point out that there are very few publications at this point about the cardiac-specific implications of this infection. There are a few case reports of myocarditis associated with COVID and concern for arrhythmias in those who have a very high inflammatory burden. But beyond that, we don't know much about the cardiac-specific effects of this infection. So with that, let me turn over the microphone to my colleague here, Dr. Mark Lewin, who is the Division Chief of Cardiology here at Seattle Children's Hospital, and who's the president for the Society of Pediatric Echocardiography.
Thanks, Matt. First, I'd like to extend my thanks to the American Society of Echo for sponsoring this webinar, and to Dr. Barker for asking me to be involved. I am participating on behalf of the Society of Pediatric Echocardiography, and I will be discussing the Seattle experience and how this experience influences whom, where, and how to image by transthoracic echo. Next slide, please. I'm going to start out with a timeline of events in Washington State. On January 21st, the first coronavirus case in the United States was confirmed at Evergreen Hospital in Kirkland, Washington, which is about 20 minutes northeast of Seattle. This patient had recently returned from Wuhan, China. Next slide, please. 8 days later, the first death occurred at Evergreen Hospital of a patient that had recently been transferred from a long-term care facility. And simultaneous with that, dozens of residents of the Life Care Center in Kirkland, Washington reported symptoms, many of whom were subsequently admitted to Evergreen Hospital. Next slide. 5 days later, there were a total of 11 fatalities in the Puget Sound area. And on that same day, Amazon, Microsoft, Nordstrom's, Boeing, and Starbucks corporate employees were told to work from home. The next day, the University of Washington suspended classes and moved those online. and 5 days later, the WHO declared this to be a pandemic. The next day, the governor of Washington State, Governor Inslee, closed the K through 12 school system. And then 11 days later, a statewide stay-at-home mandate was executed after a number of cities in Washington State had already declared this mandate on an individual city or county level. And in fact, a number of states, including California, had already issued a stay-at-home mandate several days earlier. You can see on the right the University of Washington projections as of April 6th, and you can see that in terms of deaths, hospitalizations, intubations, and the use of hospital ICU beds, the trajectory was quite dramatic towards the beginning and mid-portion of March, and that was when there were significant concerns whether the capacity would be exceeded by the demand. However, based upon these series of fairly fast-paced mandates across the state, the trajectory started evening out, as they say, flattening the curve, such that now we feel like there is potentially a flattening so that we may make this through with the current available resources. Next slide. In terms of the impact on Seattle Children's Hospital, the initial impact that flashed up there for a moment was fear. And this fear was motivated towards our worry about our patients and their families, our staff and their families, and just essentially the fear of the unknown. This quickly translated over to planning, both at the hospital level as well as within our heart center. At the hospital level, very quickly, an emergency operations center was stood up, and this was a 24/7 operation with hospital leadership so that this could be managed on a minute-by-minute basis. There was the creation of a special respiratory unit so that suspected COVID-19 patients could be admitted there in the appropriate PPE used before that patient was then tested and then moved out of that unit. There was a drastic reduction in our outpatient volumes. And then subsequently, almost immediately, there was a further reduction by canceling all elective procedural cases with only urgent or emergent cases being performed. Within our heart center, we developed communication strategies both internally and externally. We began with a heart center leadership virtual huddle on a daily basis, and that gave all of our subspecialties the opportunity to raise questions or concerns, red flags, or the need for support within their area of the heart center. And then we also developed something that many of you may be on, which is a listserv, which is distributing shared questions and information to approximately 110 care providers in 5 countries. The hospital then pivoted to prepare to support the local medical community via the supply distribution to other hospitals in need, as well as allowing for the care model to be changed at Seattle Children's Hospital so that patients up to age 30 could be admitted to relieve the stress in other hospitals. Next slide. In terms of the impact on the Pediatric Echo Lab, in terms of who, where, and how to image, next slide. Regarding who to image, we were performing studies expected to provide clinical benefit in the short term in the setting of the added risk due to potential disease transmission. We did this by defining in very rigid terms what elective meant and rescheduling those, and also defining the non-elective or urgent/emergent indications for echocardiography and proceeded with those. These decisions were guided by the appropriate use criteria established by the American Society of Echo and other societies. And in the era of COVID-19, avoiding rarely appropriate exams and potentially deferring those to a future date when this crisis is abated. Of course, this is dependent upon the pandemic trajectory, with triage by indication potentially necessary and even some appropriate and urgent emergent echoes being deferred. And of course, involving referring physicians in this triage being essential so that the appropriate care is provided to those patients in need. Next slide. In terms of where to image, Given the higher risk of pediatric asymptomatic transmission, some centers in endemic regions, including in our region, test all new admissions for COVID-19. In terms of the inpatient population, we're trying to perform exclusively portable studies to mitigate risk of virus transmission and avoid risk of wider exposure. In terms of the outpatient population, the screening protocols for infection control according to local protocols and methods for quarantine are implemented, and if possible, separate rooms and separate machines for patients with the suspected or confirmed infection were optimized. In terms of TEE protocols, these will be discussed by Dr. Barker separately. On the picture on the right, you can see the efforts that we made to not only protect the sonographer, but also the patient because of the potential for asymptomatic carriage by the use of gloves, face masks, and shields. Next slide. In terms of how to image, protocols were implemented due to the crisis, with studies performed on COVID-19 confirmed or suspected patients being designed as focused as possible, but comprehensive enough to avoid the need to return for additional images, and tailored to the indication with planning occurring in advance, and designed to minimize the scanning time to obtain the highest quality images from the most experienced imager possible. And so therefore, in the picture on the right, you can see the morning huddle that we take part in order to design some of those decision-making steps so that we can determine the most appropriate way to carry out each examination. Next slide. In terms of the role of learners, medical education, of course, remains mission critical. However, during a crisis, patient and staff safety take precedent, and therefore restrictions should be placed on trainees who are not essential to clinical care. Instead, using the American Society of Echocardiography and other providing educational offerings, including webinars and lectures, and some centers have simulators that are available to teach scanning skills without involving patients. And on the right, you see one of our cardiologists, Lindsay Edwards, doing a web teaching session with our trainees from her dining room table. So this was a highly effective way for us to be able to continue the educational mission without face-to-face contact. Next slide. So in summary, decisions and protocols around who, where, and how to image will protect your patients, their families, your staff, and your community. These decisions should be made collaboratively and should be flexible in order to respond to the fluid nature of this crisis. And I want to end by acknowledging and offering a debt of gratitude to all in the front lines of this pandemic. Thank you. Next slide. I'll introduce Dr. Piers Barker from Duke, who will be discussing the different definitions of PPE, protection, personnel equipment, and POCUS. Piers?
Thank you very much, Dr. Lewin, and thank you to all the participants who are joining us, and to the fellow writing group members. It's really been a huge privilege to be putting together this to help our community. To follow on with the two prior excellent sections, I'd like to slightly change the PPP acronym from Personnel Protective Equipment to Protection Personnel and Equipment. We'll discuss how COVID-19 is making us rethink all of these components of our Echo Labs, and we'll include a brief discussion about point of care ultrasound as well. I would also encourage readers or viewers to read the main ASE statement and view the webinar on that topic, as it covers other aspects of imaging in the time of COVID-19 in different detail. So, as we've already heard, children are affected differently than adults with this virus. Children are more likely to be asymptomatic. And when you match that to the fact that children are notoriously uncooperative in keeping their secretions to themselves, you have a setting in which adult screening tools fail, and pediatric providers are more likely to be unknowingly exposed. In addition, extra adults are usually present. There is the potential for fecal transmission, and no toddler in their right mind can be convinced to wear a face mask. Disease complexity and developmental stages make for longer scan times. This all means that it is critical to be meticulous with hand washing, masking, and other protection as per the guidelines of your institution, and that you enforce similar standards with any other adult caregiver. Next slide, please. There are a few intentionally recurring themes to this webinar, with one being the importance to maximize accuracy and completeness while minimizing scan time and personnel exposure. This means matching expected scan complexity with provider skill and being creative in using remote ways to review the scan and provide feedback for additional imaging without having another person need to step into the room. Pediatric cardiology fellows are a critical part of this team too, especially with their call responsibilities. While this is not a time for them to practice on patients, their skills can be used as long as appropriately matched to patient complexity and with appropriate backup available. It is also reasonable to try to limit exposure of staff at higher risk of COVID-19 complications, such as those staff who are older, those with chronic conditions that we know place them at higher risk, such as heart, lung, and kidney disease, those who are immunocompromised, and possibly those who are pregnant. Next slide, please. Because ECHO intrinsically links people and technology, we must also be careful about how the equipment can create risks for both provider and patient. We know there are a wide variety, a wide array of machines available with different degrees of functionality. So similar to matching personnel to scan, we must match machine to scan. This may include using a machine like a laptop machine that's easier to clean for a focused study in a COVID-19 positive patient, or in the emergency department, foregoing the use of ECG stickers, or setting aside certain machines for certain units, such as how we've done this at Duke. As an example, here are the signs on the doors of our Echo Lab rooms in which designated machines are housed: our NICU machine, our PICU machine, our BMT and cath machine. I'm sure the picture choice says something about us. I'm not quite sure what. We must also acknowledge the fact that the act of touching a patient and touching a machine creates contamination and transmission risk. So covering high touch areas as shown in the picture on the far right, and meticulous cleaning according to available guidelines is critical. There's also a question about machine fans, which is very new. Do they aid droplet spread, or do they act as a reservoir? We don't know. And this highlights the need for us to continue to talk to each other as we learn more and more and more about this disease. Next slide, please. Social distancing is now the rule. Excuse me. Social distancing is now the rule, and that must also apply to us and the common areas in which we work. There's been a lot of discussion amongst various groups about how to adjust staff and faculty schedules and what to do when not performing clinical work, but the rule must be that it must be kept at the forefront is to minimize exposure and to maintain operational readiness. This can be through creating different sonographer and staffing teams, adjusting our coverage, or assigning non-clinical but lab essential projects to maintain staff benefits. We must be creative in terms of looking to new ways to remotely read and generate reports and communicate with each other in the patient care teams. Cleaning and disinfection also extend beyond our machines to our work environment. Next slide, please. So much of what we've been discussing has been about balance and best matching resources to the clinical question, which brings us to point of care ultrasound, or POCUS. In the best of times, POCUS represents a balance between speed, indication, and disease complexity. Use of POCUS theoretically decreases the number of providers exposed to a patient if the person doing the physical exam is the same person as doing the study, and the equipment may be more easily cleaned if it's a handheld device. However, these benefits must be weighed against the costs of decreased functionality and different training that may limit the utility of POCUS to assess more complex disease. Next slide. So for now, the breadth of congenital heart disease and the challenges of functional assessment in children make traditional transthoracic echo the preferred modality. However, it's also important to look at your institutional practice, what's in place, what isn't. I would strongly argue that now is not the time to start a POCUS program. If an assessment of systolic function or an effusion is needed immediately, then POCUS can be helpful. If POCUS is performed, then image archiving is critical for review, comparison to prior studies, and to guide subsequent studies. Most importantly, the rule here is that the study must be done that answered and chosen to answer the clinical question most accurately, most completely, in the shortest time, exposing the fewest people. So I'll turn things over now to Dr. D'Onofrio to discuss specific considerations for fetal cardiology and fetal echo.
Thanks, Dr. Barker. It's really an honor to be part of this amazing writing group, and it really was an amazing effort getting this document together as fast as we did. I am representing the Fetal Heart Society, and we're going to talk about the care of the pregnant woman and the fetus. Could I have my first slide, please? Also, just want to remind everyone that they can ask questions, and please do so, because we are going to have a question and answer session after these talks are finished. So first off, a little bit about pregnancy and COVID-19. Why is this important? Well, for those of us who do fetal cardiology, we have really two patients. We have the pregnant woman in addition to her fetus, and both need to be taken into account. It's actually not known if pregnant people have a greater chance of getting sick from COVID-19 or if they are more likely to have a serious illness as a result of the infection. However, the CDC does say online that pregnant people do seem to have the same risk as adults who are not pregnant. However, they do caution that pregnant people have changes in their bodies that may increase the risk of some infections, and pregnant people have had a higher risk of severe illness when infected with viruses from the same family as COVID-19. And for this reason, they add in their statement that it is always important for pregnant people to protect themselves from illnesses. Next slide. So my questions that I'm going to try to answer are the same as the others. And I'm also going to add a little bit about delivery room considerations as we transition from fetus to baby for our patients. So the first thing is where to image. Well, the goal is always to minimize exposure, and that's to minimize exposure of the pregnant lady to everyone she comes in contact with as she leaves her house, and also to minimize exposure of our staff to the pregnant woman and her support network. So rules are first to avoid the hospital when at all possible, to use lower volume outreach clinics perhaps, to avoid intermingling pregnant women with peds patients, particularly if imaging is done in the pediatric cardiology office. Consider using the MFM office, or if that's not an option, to sequester pregnant women from the kids, both in the waiting room and in the echo lab. Consider telemedicine, both the standard and novel ways of using telemedicine by maybe even reviewing cardiac screening studies that are done by the obstetrician, reviewing studies done in those lower volume, low risk facilities, and then reading those remotely, counseling, second opinions, and even considering if you have the ability for home fetal heart rate monitoring to maybe manage arrhythmias and autoimmune mediated disease. The guidelines for fetal echo visits, only one support person at most should accompany the pregnant woman to the visit, and that person must undergo the same screening process as the patient. However, no matter who accompanies the pregnant woman, the scan room should be limited to that pregnant woman and the sonographer alone. And then counseling should be limited to the pregnant woman and, again, at most that one support person. Keeping in mind social distancing, trying to find counseling rooms where there's perhaps a larger room to maintain that distance. Next slide. So how do we image? Well, PPE for sonographers is important. We've already talked about this. Masks, gloves, and recently at our institution, we added eye protection. The protocol for fetal echo, we believe it should be a complete study for all new consultations, and that's in order to minimize the need for any repeat evaluation. There are well-defined study protocols that are available through various societies, including AIUM, AHA, and ACE, and if you're not familiar with those, perhaps include an imaging checklist in the scan room. The study should be reviewed by reading physicians prior to the pregnant woman leaving the exam room. Follow-up scans should, only if they're deemed necessary, and we'll talk a little bit about this, should be focused based on predetermined checklists. And this is a good time for a huddle between the sonographer and the fetal cardiologist before the exam is performed. Prolonged scanning should always be avoided. We've already talked about trainees and inexperienced people doing the scans. And transvaginal fetal echocardiographic studies should not be performed during this time. Next slide. So who to image and then actually when, which is important for our fetal patients, is fetal echo visits should be triaged such that only those with moderate or high fetal risk are scheduled. How do we determine this? First off, the likelihood of congenital heart disease compared to the general population risk, which is the referral indications. The adequacy of the OB second trimester anatomy scan with cardiac views, and it depends on your local resources as to how you're going to do that. Do you have a working relationship with that MFM group that you know they're going to do an adequate scan, or do you need to review those images? The gestation becomes very important for our patients. Those who are less than 24 weeks, it is considered perhaps a high-risk indication because pregnancy decision-making as well as need for additional testing like amniocentesis is often needed. And at the other end, greater than 34 weeks, particularly if there's congenital heart disease, those scans need to be performed for delivery planning. Certainly any fetus where there's a potential for treatment should be considered high risk. It mostly includes the tachyarrhythmias and the bradycardias from autoimmune mediated disease. We did try to think about the potential for treatment using fetal cardiac catheter intervention as part of the statement. However, if you think about the data on the long-term risk benefit of these procedures, these interventions should be at the discretion of the fetal care center. Next slide. I think perhaps the best part, at least from the fetal part of this for this statement, is the table, which I've printed out and posted in our lab, dividing patients. So the low-risk patients, which are those low-risk referral indications, and the examples are listed. If there is a anatomy scan, which with a cardiac screen that you can then say the views are adequate to say the heart is normal, those patients should be either canceled or not scheduled at all. Next slide. In the moderate risk group, these are patients that have a higher risk referral indication. However, the gestational age of greater than 24 weeks or less than 34 weeks is in that period where really no intervention is being entertained. And so they do need to be scheduled, but thought needs to be put into scheduling them at minimal risk. So when the COVID-19 risk is believed to be going down, or at least in the third trimester after 28 weeks. The examples for these diagnoses are listed: second opinions for heart disease if you can't confirm the heart is normal, or these high-risk indications like pregestational diabetes, an increased nuchal translucency greater than 3.5, or very specific congenital heart defects and first-degree relatives. Next slide. Our high-risk patients, the fetal echo should be scheduled and performed promptly, though certainly we should consider alternatives in order to maximize safety. These are the urgent clinical indications. It's mostly the treatment of arrhythmias. But what's important to consider again is that gestational age. If it's less than 24 weeks or greater than 34 weeks, then that scan really does need to be done. And you can see the list of examples: suspected or known heart disease, high-risk indications are really the indications where we're doing scannings promptly. Next slide. So when you put it together in a pathway in the low-risk patient group, you need to determine the adequacy of the cardiac views on the OB scan. If the structures are normal, then you cancel or do not schedule that study. If the cardiac structures are not confirmed, then depending on the gestational age will determine what you do next. In the moderate risk group, they do need to be scanned, but it should be thoughtful and to the timing when the risk is less. And in the high risk group, obviously they do need to be scanned, but really try to think about how to minimize that risk. Telemedicine really should be utilized whenever possible for multiple different indications. And then finally, just a word on delivery considerations. Vertical transmission from mother to fetus is believed to be unlikely, though the data really is inconclusive. There are 3 studies out there, I have them listed. Only one of those studies suggests that there may be vertical transmission. 3 newborns tested positive by throat swab within the first few hours after delivery. However, there is not enough data to say that there is or is not vertical transmission. What this then leaves for us, next please, is that many centers are now instituting universal testing of pregnant women on labor and delivery to determine the risk in the newborn. And then for COVID-19 positive moms within 14 days of delivery, the newborn must be tested and treated as positive until a negative result is confirmed. Next slide. So in summary, patient triage is really important to determine a need for a visit. We've already talked about how you do that. We need to consider telemedicine options, heart rate monitoring, certainly PPE for sonographers and medical staff, and maternal COVID-19 status is very important for delivery planning. Thank you. I'm now going to introduce our fearless leader, Dr. Barker, who's going to finish up with transesophageal echo.
So yes, so thanks, Dr. D'Onofrio, and thank you to whichever member of the webinar team came up with that transition slide. It's one of the best things about being part of, I think, our pediatric community is that even in the midst of a pandemic, we can't take ourselves too seriously. So for TE, so of all the echo procedures we do during this time, TE is likely the highest risk of them all. It can't be avoided. It can't be deferred, it can't be rescheduled, since it's integral to so many interventions that need to occur regardless of the pandemic. Yet at the same time, it exposes providers directly to the region of the body that has the highest viral load. The highest risk is definitely in the unintubated patient due to all the coughing and gagging, but fortunately that's really a pretty rare situation for us in pediatrics. The risk of aerosolization in an already intubated patient is unclear. There is not good data to suggest that it is, to quantify that risk. It is certainly lower than in an unintubated patient who's coughing and gagging and sputtering. But even acknowledging that that risk is lower, we also have to acknowledge that there is a risk in doing TEs in an already intubated patient from cross-contamination. You'll have a hand near the patient's mouth, then near the machine, other people might come by and touch the machine, and so on. That means that other imaging should be considered unless TE has to be performed. So for instance, off-axis transthoracic views, agitated saline contrast, intracardiac echo, epicardial echo, even CMR or CTA, although for the latter two, acknowledging that there's a transport risk and that a different scan room will need to be cleaned. Many institutions are moving forward with universal pre-procedural screening for SARS-CoV-2, which has the potential to be extraordinarily helpful. However, I think it's most important to consider approaching TE as a distinct procedure with an algorithm developed in collaboration with all the different groups that are going to be involved. Next slide, please. As one example, here's a TE algorithm to consider. Really starting with the question of whether or not TE is necessary for perioperative care or interventional guidance. If it's not necessary but requested, then the question becomes whether or not alternate imaging strategies are available. If yes, then do them. If no, then proceed with TE using the precautions on the left side of the screen. If TE is necessary or it has to be performed, then it really comes down to looking at the patient's COVID-19 status. If it's negative recently before the procedure, then you can perform TE using standard precautions. If it's positive, then the procedure is done under strict isolation with limited personnel, having anesthesia place both the endotracheal tube and the transesophageal probe at the same time, using airborne precautions, and then waiting whatever length of time is necessary for a complete room air turnover to occur. If the COVID-19 status is unknown, then we're in a little bit of a gray area. And that may partially depend on whether the patient is intubated prior to arriving in the operating room or the procedural room. If they are, then that is lower risk. And so you could consider doing the TE and probe placement using standard precautions. However, You could also consider using airborne precautions in this situation. Again, acknowledging that this risk is unknown and that there is a need to conserve PPE. If the patient is not intubated, then I would presume that the patient is positive, and then do your intubation probe placement, air turnover period, all the same. Next slide, please. Most important with all of that, however, is working to develop with your institution a system that is going to work for you, and including in that algorithm an acknowledgement that an equally important part of the procedure is to have a corollary process for protecting providers. This process is outlined courtesy of the just released ASC Council on Perioperative Echo Supplement, released on Tuesday, which I'd also encourage everyone to read. Key points include covering high-touch areas, double gloving with virucidal cleaning of the inner gloves when necessary, and appropriate probe cleaning before safe transport and further decontamination. Next slide. So in summary, I think we can have several recommendations. One is to defer and reschedule scans if possible, assess and ideally know the patient COVID-19 status, regardless of the type of echo you're doing, provide appropriate level of protection for patient and provider, limit the personnel and exposure during the scans, match the provider and the equipment to the scan indication, develop and use institutional algorithms for TE and POCUS, reduce echo lab and reading room transmission, and make sure we're all doing our part to conserve the PPE that we do have. Next slide. But most importantly, I think we need to think fast. This is probably representative of the entire experience we're having with this pandemic. And I think for echo, we can think about focused, accurate, safe, and thorough scanning when we're approaching a transthoracic study, a POCUS study, a fetal study, or a TEE. And always, always, always we need to communicate and collaborate with our sonographers, our fellows, our adult cardiology colleagues, anesthesia, maternal fetal medicine, pediatric, and nursing colleagues. We are all truly in this together. Thank you.
Thank you to all of our panelists for those really helpful walking us through the supplement materials. And I think we do have some time now for some questions, and I have looked at them, the ones that have been submitted, and kind of grouped them a little bit, and will send them out to you all now. One question that is for all the panelists actually is to comment on the individual institutions' experience so far. Have any of you had children with congenital heart disease test positive for COVID, and what has been their clinical course and findings? And have you had experience with any patients who have not had congenital heart disease in the pediatric age range group with COVID affecting myocardial function or rhythm disturbances? And I will ask each person in turn, but I'll launch an initial observation that here at Texas Children's, we have not had patients present with congenital heart disease requiring ICU admission for COVID positive issues. I have spoken with the cardiologist in New Orleans, and they have had two children, a 12-year-old and a 17-year-old, both with no underlying health problems, both with myocarditis and severe rhythm problems. One presented with sudden death event actually and was found to have a severely edematous heart with evident myocarditis on autopsy, and another one with complete heart block and severely depressed biventricular function. So I do think, although rare, we may be seeing events in the future in our children, and I'd like perhaps starting with Mark and Matt to say what the Seattle experience has been.
I'd like to defer to Matt on that. We have not seen any patients with congenital heart disease. I think Matt can probably give a broader experience about the hospital as a whole.
Yeah, absolutely. I agree. No patients with congenital heart disease. We've tested just about 1,500 children. Most of those were symptomatic until we moved to routine pre-procedure screening. And I think 15 total positive, so around 1% of our tests turned positive. And yeah, no other cardiac issues due to the COVID that I'm aware
of. Mary, how about at Children's National?
I think we've been lucky as well. We've had a couple of COVID positive kids. One of them was sick, but also had a tracheostomy So far we're lucky, but I don't think we're at our peak yet. So we're certainly prepared for it. Did have one kid who I saw in the clinic who had aortic stenosis, who was tachypnic, and so went through the whole COVID protocol. And it's kind of interesting how we have to navigate that, because obviously many of our patients have those symptoms anyway. And if you have to do the 2 times testing is what we're doing 24 hours apart, do you do that for tachypnea when you've got LV dysfunction and need to move forward? I think these are challenging times, certainly for all of us.
Piers, what about in North Carolina?
So I think we've been similarly fortunate, although we're not predicted to hit our peak for another week or two. So no patients with congenital heart disease and COVID-19 yet, and hopefully not.
I think this will come down to we'll need to cohort our patients to gain experience as a whole, since hopefully individually institutions will not have a big experience. It looks like there are a number of questions about what types of devices people are using if they are doing POCUS type evaluations. So a question to Dr. Lewin and to Dr. Barker on what kind of portable devices are you using for your POCUS studies?
So we're discouraging POCUS studies just because of the expectation that we're going to have a one and done kind of situation where the patient is exposed and the staff are exposed once. And so we're doing all of ours in our standard echo lab scenario, where a patient is either imaged in the emergency department, ICU ward, or clinic by an experienced sonographer.
Piers?
Yeah, similarly, we the main modification we've done is we've taken one of our laptop portable machines that we usually use in a neuromuscular clinic and designated that for the emergency department use, or for if we do have COVID-19 positive children, we can use that. It's easy, it's fully functional, but easily cleaned, and really bringing up the expected probe you're going to use for the scan, instead of bringing up every single probe that can attach to the machine, again, to try to decrease transmission. I agree with what Mark is saying. I think it's, you want to get the most information with the fewest people. And, we know that different systems have different degrees of functionality, different degrees of transducer frequencies. And I think one other thing to consider in the POCUS and COVID-19 discussion is that it's not just potentially moving a provider into and out of the room and increasing provider exposure risk. But you've got to, if it's a patient in the ICU who's ventilated and who's prone and who is really, really sick, then moving them around multiple times to have different people go in and to try to get different images actually increases patient risk as well. So I think all the more rationale to really think ahead about what you need, what you want from the study, and designate the personnel and the equipment that's going to give you that information as quickly as possible.
There are several questions here about personal protective equipment for our sonographers, and there's interest in the eye protection for the sonographers, and whether that's being done for all fetal studies and pediatric scans in your institutions. We have not yet started doing that here at Texas Children's Hospital. So I understand, Mary, that you're doing that for all your fetal scans. Are they for pediatrics as well?
Yes, that was, thank you, Carrie. Yeah, that was just instituted this week, where initially we were going with the masks and the gloves and gowns. But, given the false negative testing rate of about 20 or 30%, we felt the need to protect our staff and instituted goggles for everyone doing those kind of close contact studies. So that would include fetal studies as well as all of our pediatric echocardiograms.
And Mark, did you want to expand on any of that?
I'm going to let Matt talk about that, and also maybe he can talk about sensitivity and specificity depending on which lab is doing the studies, because that might raise concerns when they hear Mary's comment about the predictive value of the testing. But we've decided about, Matt, maybe about a week ago, that all inpatient and outpatient face-to-face encounters would use gloves, masks, and face shields. There was a question here about the picture that I showed of the sonographer whose face shield doesn't protect the side of her face, and whether people are using some modification of that for sonographers so that there's less exposure. I haven't heard about that, but there may be others who have. Matt, did you want to jump into sort of a general rule about what's going on at the hospital?
Yeah, well, I'll really just address the sensitivity specificity question. So one thing that hampers us here is that we don't have a gold standard test to compare to. Usually that's what we use when thinking about the sensitivity and specificity. We do know that the analytical sensitivity of these tests can detect down to 1 to 3 virus particles per microliter, so 10 to the 0 to 10 to the 0.5, whereas we expect that there are around 10 to the 7 or 10 to the 8 virus particles per microliter in the nose. So they should be able readily to detect virus if it's present there. But as we talked about before, because people can be asymptomatic, that's part of why we moved to using the eye protection and gown, glove, mask, even for asymptomatic patients in the outpatient setting when we're not testing them. But we generally think that the analytical sensitivity and specificity are high, 95% or more for each of those. The reason a test might be false negative is either it's tested too early or poorly obtained. And there are some differences between manners of testing, whether it's looking for certain envelope proteins or the RNA-dependent RNA polymerase. But for the most part, we think that these tests really ought to be quite good.
I think that also tags into some of the questions about the TEE and protection in the OR. There's a lot of questions here about TEE safety, and I know that our own institution has moved to testing everyone who comes into the CVICU, anyone who comes into the cath lab or the ORs when there's enough time to actually be able to do the test and get it back, and we have that within 24-hour turnaround. So I'm interested in knowing what the other centers are doing, and if Matt might want to comment on Seattle's experience with that too. Maybe Matt first.
Sure. Yeah, happy to. So we are, in fact, screening everybody who's admitted and everyone pre-procedure. And we're very fortunate because we have local labs that can turn these tests around quickly. Our average turnaround time is about 6 hours, actually, and we don't have tests taking longer than 12 hours these days. So we really can have rapid information prior to any kind of procedure and shortly after admission.
What about the situation at in Washington, Mary?
Regarding the testing?
Yes, preoperative, pre-procedural testing.
Yeah, I mean, I think it's every day it changes. And I think certainly as we're starting to get towards what we anticipate to be our peak, we are testing and trying to figure out the best way to do it, you know, to try to learn as quickly as possible when someone is positive. And I think for our testing, certainly any kind of procedure that needs to be done, those patients absolutely are being tested. And anyone who comes into our hospital who has any positive screening factors, whether it's just a cough or a fever, any kind of respiratory symptoms, they're tested. Certainly, like I said, I think it's mostly the procedures that we're concentrating on. And as far as dealing with our testing, we're doing 2 tests within 24 hours, which then gets us up to what my understanding is that higher sort of confidence of, you know, 95% that it's accurate.
It certainly is an evolution in practice. We started out being able to test once a day. Now we're testing once a shift and getting results back ever.
Absolutely. We've also set up a tent outside our hospital for testing, where even other providers can put in a kind of prescription and be tested. So we're doing a lot of those tests as well. The turnaround time of those tests are longer, like 6 or 7 days is my understanding. So it's interesting the variability that you have with the kinds of tests and how long it takes to get the answers.
Just to go on a little bit different tact, back to Mary for one thing about how is your institution and then other institutions handling their pregnant medical providers, knowing that while we haven't gotten any data that pregnancy is conferring higher risk, but with the suspicion that it seems like it should be, how are y'all handling that?
Yeah, I mean, that's exactly right. I think, you know, we have to consider, at least theoretically, the pregnant women are slightly immunocompromised, perhaps, and really are taking care of them for sure, trying to keep them away from those kind of higher risk situations. You know, but I think it's the thing is that we need to learn more about this. Other viruses, and Matt can comment, certainly have affected pregnant women more significantly. And even this vertical transmission thing, it's the unknown is the scary part. And I think as we get more experience on this, understanding this virus, you know, we may be seeing fetal effects. I mean, in other diseases, the same sort of viral types, there's a higher risk of preterm labor, growth restriction, fetal loss. And so I think it's important for us to be cautious, certainly of the pregnant women we take care of, but also the pregnant women who are on our workforce.
Excellent. And there are some questions here about strain and assessing myocardial function in these potential PUIs or COVID positive patients. And if anybody has any experience with that, I would like to hear that. It may not be so possible because it doesn't sound like we have a whole bunch of positive patients impacted amongst our group. Piers, do you have anything to comment about that from Duke?
So I'm not aware of any data on strain or specific functional abnormalities that wouldn't be relatable back to like a myocarditis process happening from this viral infection. However, that doesn't mean that there's not utility in having the ability, and it wouldn't be useful to have the ability to do additional functional measurements in these patients. And a couple of questions that have come up in terms of POCUS versus limited transthoracic echo. And again, I think this would be an example where having a machine that you can record images and then do later strain on, or having a machine where you can use pulse wave Doppler to do different, or tissue Doppler, can give you more information about how the underlying disease or cardiac or respiratory process is affecting the patient. With that said, there was also a really good point made on the adult main ASE statement webinar, which said that when you're doing scans in a patient, COVID-19 positive patient or under suspicion, again, you're trying to maximize data in a minimal amount of time. So that would be a setting in which you would do your measurements outside of the scan room. Get the images, get out, do the measurements offline or post-scan.
Thank you. Another question I was just going to throw out here is about how are people handling their reduced staffing, and are there any creative approaches to work with the sonographers and teams? And so maybe starting with Mark, since you've probably been dealing with this longest, as far as how are you handling your reduced staffing and for sonographers, and also maybe a comment about are you doing a lot of remote echo reading?
Sure. So I think it's a really important question. A number of avenues. Number one, the fact that we've greatly reduced our volumes in clinic and in procedure areas, it means that staff are getting sometimes no pay days, and that is a problem, just like it is for the general community about people being laid off from work. And so we've been trying to mitigate that by finding opportunities for educational protocols and QI and research activities for those people to do to keep them fully employed. And we hope to be able to continue to do that through the remainder of the crisis. It obviously is a balancing act because we also want to protect those staff from being at the hospital if they're going to be potentially exposed or exposing if they're asymptomatic carriers. So we're still working through that, honestly, and I wouldn't say that there's a perfect answer. The other part of your question was in regards to
remote echo reading.
So remote echo reading, we've been talking about that. We certainly do screening remote echo reading weekends and nights, but we don't sign them off, and we haven't implemented that yet. We have gone to a reduced faculty level in the echo lab in order to, for the same reasons that I described before, and that has been adequate to cover both the OR and the other inpatient areas and the echo lab with reduced faculty because of the reduced volumes. We certainly could try remote reading, but of course, those are compressed studies, and so there is some potential risk there as well.
Yes, at Texas Children's, I would say that we have been working with our sonographers and our quality improvement teams to take this opportunity to really work on several projects that have been long needed in the lab as far as improving education and quality in the lab, but we are also struggling with the need for reduced work hours just as it is across through the institution. So you have to be creative and be supportive in a really stressful time. Mary, do you have any other comments? I don't think we have too much time here, but any other last comments about that?
Yeah, I think a couple of comments. I think you know, we've been very successful with remote reading. I think our lab has been established with that for a while. So we've been able to read remotely and have just really increased that in this time. What I would like to say is that if there's anything good about all of this, it's really made us all be much more collaborative. And, you know, many of the outside offices in particular, given that I'm a fetal doctor, the MFM groups, we've been trying for telemedicine connections with all of our providers in the surrounding communities. And there's a resistance to it, you know, and complacency that now at this point, we've all banded together and we've set up successful telemedicine connections in you know, 6 or 7 offices within a 1-week time frame using lots of innovative solutions and technology. And so my hope is that this, when this is all over, this continues and we continue this kind of collaborative effort and really being able to reach out into our surrounding community to help care for our patients.
Well said. I think that is one of the silver linings of that for sure. I'm going to go to Piers to see if he has any other last minute wrap up comments because I believe we're reaching at the end of our time.
No, thank you. I think we can go to the next slide, I think, has some resources that people can look up. These are just a few. There are some other ones in the document itself. But I draw people's specific attention to the ASC COVID-19 resource page. The supplement from the Council on Perioperative Echo is there as well. The AIUM has guidelines for equipment care during this time. Obviously the CDC, a number of different organizations. I think it is an understatement to say this is a rapidly evolving situation. And so, you know, what we're presenting today, we may need to be rediscussing in another week or another 2 weeks. And I certainly, as over the next few months, we'll understand more and more about how this impacts children. I'll let Carrie wrap everything up, but do let me add my thanks to all the people who watched, to all the people who are caring for patients and all the people who are caring for the caregivers. And of course, our thoughts to all the people who've been affected by this disease across the world. Carrie?
Thank you. One last thank you to our sponsor, Hitachi. Next slide. ACE has a lot of benefits to offer for its members with regards to COVID-19 in addition to its public access sources. So this is how you can join. Next slide. And thank you very much. I would echo very much my appreciation to Mary, Piers, Mark, and Matt for participating in this, as well as the other members of the writing group for putting together our supplement in record time, and really hope that this is helpful to the members of our community in caring for these patients. We know it's a very difficult time, and taking care of ourselves, taking care of our staff, and so forth. If there are questions that were unanswered, we will continue to look at those and try to answer them back to you individually at some point here. And again, this will be recorded and available by tomorrow, I believe. So thank you once again, and thank you for the American Society of Echo for helping on this.
Carrie,
Yes?
this is Mark. Can I just make one comment? There was one question about the listserv that we have, and I know that I could answer that one person individually, but if people on here that are interested in participating in that listserv, they can just email me directly and I'll add you to that, and then you'll be able to communicate with the larger community. That's at mark.lewin, Lewin, at seattlechildrens.org. Thanks, Carrie.
Thank you, and thank you again.